Hello, everybody. I have to start by saying I'm very, very inspired with what I heard this morning. I travel quite a lot since we have activities all over the world, from Latin America, the US, Europe, to Kazakhstan and China. And it's excellent to be able to see that this paradigm shift to view the patient as the key focus of what we do within healthcare has actually started. And you can see it everywhere in the world. It's really great to see. So I'm Christina Sтернер, and I've been part of Diaverum since the start. And I will start by setting the scene of the chronic disease that we help to care for, and then try to explain how we manage quality and how we thus create value for the patient, but also for the societies and those of us who pay for the service. So if we take a look at the first slide here, we see that in the world there are 7 billion people, and actually 10% of those people have some sort of chronic kidney disease. There are 5 stages of chronic kidney disease. CKD is the abbreviation. And it's not until you have reached this last stage that you need some sort of renal replacement therapy, which means that you either have a transplant or you need dialysis. And this means you need to go to a dialysis center and get dialysis either you do that 3 times per week, and you have a treatment that takes about 4 hours. And you need to do that for the rest of your life, unless you get a new kidney. And you can do either hemodialysis in a center, or you can do peritoneal dialysis at home. And there are about 3 to 4 million people who have reached this stage. And this is actually without counting China. And this number will probably double within the 5 to 10 years because of some of the trends we see in the world. So this is what we are facing. We have the demographics, older populations with several illnesses, often due to the lifestyle they live, so obesity and diabetes and heart problems are all unfortunately, many of those people who have those diseases end up getting kidney problems. Also, patients want to be treated closer to home. So this is a difference compared to how we have normally set up our healthcare systems for acute care. But these, and also more and more of our patients are actually chronically ill. So this means that our healthcare system is not really catered for them. And they want to be treated closer to home so that they can actually continue with their lives and work, etc., and provide for their families and for the society. Also, empowerment is a trend that we can see, that our patients are actually, from our perspective, our customers, and they are more informed, they are much more demanding, and that's actually good. We should view that as positive, because we need the patients to also understand their illness and try to care for themselves. We can try to inspire them, but they actually have to make the choices once they leave our clinics, the right choices. Also, we see a trend towards transparency, as we have talked about several speakers today. You, as healthcare authorities and payers, will and you should demand more information and increased quality for the service that you pay for. And this means that we need newer reimbursement systems and incentives that actually create value, which is also what we have talked about now. And in addition, we start to see that we have new care models coming up. We talk about integrated care, for example, that we coordinate care around the patient. So if we take a look at that, and include more and more services around the patient that are linked to those patients. For example, our patients come to our clinics then for, it's almost like a half-time job. So 3 times per week for 4 hours. And if we can coordinate other needs that they have in our clinics, that is beneficial both for the patients, but also for the system. And this is our strategy also. We have different pilots around coordination of care and other types of new care models in Germany, Portugal, France, and Argentina, to just mention a few. Then just to give you a quick look at who we are and where we operate. We are present in 20 countries, and we have over 360 clinics with 10,000 employees that are caring for 30,000 or over 30,000 patients. And we actually are very happy that we are also here in Russia with several clinics. The good thing with being in several different geographies is that we learn to handle different setups. So we are active in geographies where there are both tender markets and non-tender markets. In Germany, for example, we can buy licenses, doctors that have licenses to operate dialysis clinics. And in Sweden, for example, it's all about tenders. So there's a public tender and we can bid for it along with our competitors. There are also then different reimbursement systems, so we need to be able to handle them. And there are different regulations, which also, of course, affect the reimbursement system. And with all of these different systems, we have quite an experience of how to handle different setups. So now, if we do get into the main topic today, how do we work with quality management? We have a very consistent way of working with quality management. One of the main things is, of course, that we focus on patient care, just like a hospital would, like Barbara Fredén was talking about. The focus is care. We have no products and no links to the product industry. And all of our clinics are ISO certified. We, of course, follow evidence-based guidelines and clinical protocols, of course, the way you do as well. We do have global policies and global procedures, but we also localize them to make sure that it works in the setting that we are in. And one really important thing is that we set medical targets for all of our clinics across the globe. They have the same targets. We have internal and external audits, and we have a 100-day and a year integration program that we work with. And if you look at some of the measurements that we have, these are the hard measurements, you could say, clinical performance measurements. You recognize some of them, KT over V, albumin, etc., etc. And we are measuring these in all 360 clinics once per month, and then we compare how we're doing. So, like we have talked about several times today, what gets measured gets done. And we are very, very proud of the fact that we keep improving. And when we take over clinics in any part of the world, we are able to improve the medical outcomes quite significantly. We have done these measurements for over 10 years. And the key thing with doing measures, as several of the speakers have talked about today, is to learn from the measurements. And with the learnings, we have created a standard of care that we use across our clinics. And that is basically the basis for how we do our treatments. Of course, it's also important to continue to develop, and we do several different research projects around the world that are published in both the Lancet and BMJ, etc. The key thing with these research projects are that they are based on what the patients actually want us to have a look at. So we base all of our research approaches on that. Another key important factor for our quality management is, of course, to have a very highly trained staff. And we have recently launched a new training platform called the Academy. And we have training programs there both for the patients, for the nurses, for the physicians, and for our clinic managers. We all need to learn different things in order to improve for the patients. And the key thing that we've also talked about today from several of the speakers, what is the key thing in a quality management system when you deal with patients? It is, what do the patients think? How do they experience the care that we give them? We measure what the patients think about their care, at least twice per year, but in many places more. Since our patients keep coming, we cannot do it every month because it's going to be too much for this type of patient. But we measure them, and we follow this, and it's actually an external company that measures this for us. And we also measure the employee satisfaction, and we actually do link these two surveys, because we can very easily see that when the staff is satisfied, you can also see that the patients are much happier with the care that they get. So this is very important for us on how we deal with our staff. And so with all of these measurements that we already do, and we are very, very proud of our quality management system, why do we need an institute like ISHOM? Well, I think this is extremely important. We need to join forces, because Diaverum, we have our own way of measuring. That's not enough. We need to have one standard set of measurement so that we can compare. How does it look in Ufa compared to Yekaterinburg, and be able to compare apples and apples. By having that, we will be able to learn. So I will just quickly go through one example, and you can see this as a case of how ISHOM works. So I'm also a member of the European Renal Care Providers Association, which have teamed up with ISHOM and many other institutes and organizations around the world to create a standard set for chronic kidney disease. And you can see here that there are several different organizations around the world who have been working on this. The focus has been on high-risk chronic kidney disease population, and as you can see on this slide, it is one important thing is to work very structured and decide on what to include and what to exclude, and look at which type of treatment modalities should go into the standard sets and which should not. We have also had a two-tier implementation model. So which are the important, the essential measurements, and which are the important ones. So the essentials are the burden of care, the patient-reported outcomes, and the modality-specific. And then this is a way to show that for the different modalities. And also the case mix variables is an important thing to include, which has also been presented by some of the other speakers. Demographics, baseline characteristics, etc. So actually in October, so only a month ago, the final standard set of chronic kidney disease was published. So now we only need to implement this to make sure that we can start to compare between each other. Because to end with, I want to say that the whole idea with measuring outcomes is to make sure that we will be able to treat our patients in an even better way, because that's what this is all about.
Кристина, большое спасибо. У меня один маленький вопрос. Может быть, я прослушал. Скажите, среди тех центров, которые сегодня включены в ваш проект, есть ли те центры, которые работают в России?
We do have centers in Russia, yes.
И как они выглядят по сравнению с другими центрами, которые работают за пределами Российской Федерации?
You have very nice clinics here as well, but we can, the clinics we go into, and I would say that they look very nice compared to other places in the world, but we can still improve the quality. We improve the quality of care when we go into clinics in Germany, when we buy clinics in Spain. So we can improve everywhere. But I think that you have quite a high level of care in this country. Absolutely.
И эти данные относительно работы центров, они открыты? Информация?
In what way open?
По сравнению, по всем показателям, по всем исходам работы различных центров, в том числе российских, эта информация где-то открыта на каких-то источниках, веб-сайтах?
Not to my knowledge, no, not a complete register like we have, for example, in Sweden, which would be good, because we would welcome that.
Спасибо.